10 o'clock, so Nate's going to record Mary's presentation. I know that you have that she's prepared, and this is an important topic for everybody. And I know you all come from different, different exposures to various ways of doing a spiritual care assessment. But I think we're going to welcome Mary's information today, and we'll go ahead and let her get started, and then we'll kind of do a roundtable afterwards.
Sounds like a plan. Okay, so just kind of going around the faces I see here. Jamie, I've met you. Mike, I've met you. Loretta, I've known forever and a day. Nate, you're new to me, but we'll figure it out. Roger, I know really well. Bill, hi Bill.
Hi,
and David
morning.
Swanson. There we go. Greetings, everyone. Good to see you all. So glad for your service to Enloe and the provision of spiritual care. It's a huge component of healthcare, and as you know, it's a much needed aspect to provide to our patients. So one of the questions that was brought up to me a while ago was, how do you do an assessment? How do you figure out what a patient needs spiritually? And there are levels of this kind of triage that start as soon as a patient comes into the hospital and is admitted. So I'm going to pretend that Enloe does every single step, and I'm going to walk you through that. And then I'm going to indicate what a spiritual care volunteer is able to do, and then what a spiritual care volunteer is not able to do because you don't have access to the medical chart and you aren't creating a care plan to follow up on. But I can still teach you some assessment tools and some ways to get the conversation going. So, first and foremost, the question that I think begs to be answered is, what is spiritual care? Most people have a vague idea of what that is, and it's based pretty much solely on the faith tradition or spirituality that the person practices. Spiritual care in the clinical setting is, it's a discipline. Okay, the discipline of professional spiritual care is both a quality of being in the world and a collection of techniques and skills. Spiritual care is neither science nor art, but a craft that combines theoretical, technical, spiritual, and theological principles with an inner intuition, vision, and a kind of artistry. Spiritual care is a sacred and relational craft, and spiritual care empowers patients and their loved ones by mediating compassion in the here and now and the moments of crisis, transition, and loss. There are some very basic values and norms associated with spiritual care. These are kind of the values you need to adopt as a spiritual care provider or a chaplain director. The values are, number one, healthy self-awareness. That was the very first study I did with you guys. When I said self can't reveal self to self, and that's why we go through CPE training, so we know what we are like, what our triggers are like, so we don't transfer it onto the patient. So the number one value needed for any spiritual care provider is self-awareness. You need to know yourself. You need to know your strengths. You need to know your weaknesses. The next value is an ability to function non-anxiously in crisis. Now, as we know, most people coming into the hospital are vulnerable. They're anxious. They can be angry. They can be berserk with pain. They may be going, oh crap, here we are again. I thought I was over this. There's a lot of emotional turmoil that comes with coming to the hospital. And the spiritual care volunteer and the chaplain needs to cultivate that ability to function non-anxiously in crisis. You are the rock and the stream is going around you. You are that center point place of peace that people can anchor to when everything around them is crazy. The third value and norm for spiritual care is to be rooted in your own spiritual or religious tradition. Okay. When you become a chaplain, you have to be endorsed by your denomination or body. Like Buddhists have to get endorsed by their setting. I'm endorsed by my denomination. And that endorsement is a level of accountability that keeps your ethics maintained and makes sure that you have a way to take care of yourself. So you have to be rooted in your spiritual and religious tradition, and you have to be accountable. The fourth value is you need the ability to take multiple perspectives. A former bishop of mine, Lee Parker, he once said, you know, there aren't two sides to a story. There's 10 or 11, and there's usually truth to all of them. So you have to be able to listen to everyone's story and see how it blends in with the patient's story. Or like you could be in a room and the patient is one faith tradition and the rest of the family is something different, or 10 others. And there might be other cultures present too. So you have to learn to just soak in all that perspective and appreciate it. One of the huge parts of values for spiritual care is this phenomenon we call cultural humility. Cultural humility does not assume that the culture of your origin is best and is not dominant. Cultural humility asks questions. Cultural humility understands that there are other perspectives out there that are going to inform people's choices, and you aren't trying to maneuver people to a choice. And so that cultural humility includes no proselytizing. Spiritual care volunteers and chaplains, we don't proselytize at the bedside. Remember what I said at the beginning? People are vulnerable, they're exploitable, and people do not like having a heavy-handed approach to them when they're in the hospital. And so that's not the role of a spiritual care volunteer or a chaplain. Proselytizing is outside of the hospital. The next value is clinical professionalism. You got to get along with everyone, even the people who don't treat you nicely. You have got to get along with everyone. And if someone's got a beef with you, then you've got to learn to talk to them about it. You know, my second unit of CPE, one of the things they brought up was, Mary, you avoid conflict and controversy and you run from it. I'm like, yeah, that's how I survive. And they're like, no, that's not what works in a hospital. You have got to learn to say, hey, that doesn't work for me. Or you need to be able to say to a doctor, whoa, slow down. This family needs to pray before you take him to the emergency room. My first unit of CPE, I wouldn't have been able to do that. And so learning how to interact with these people and be a good team player, that's a huge part of being a spiritual care volunteer and a chaplain. And then the final value, number 7, is emotional maturity. In a nutshell, it's not about you, you know, and some people may get angry at you. Some people may criticize your work. So be it. You've got to let that roll off your back. It's not about you. It's about them. And you need to keep it about them and be able to take it. So in a perfect hospital system, spiritual care begins at the intake questionnaire by a nurse or a social worker. Upon admittance to the hospital, at some point, a patient should be asked, would you like spiritual care support? Now, that is just a question, a questionnaire. It's a yes, no, pretty much, that's it. So what's good about this question? I'm just gonna throw it out there rhetorically. What's good about this question? Do you want spiritual care support while you are here?
Well, it announces that that support is available.
Yeah.
And that may not be even on their radar if they're thinking medical.
Yeah, that's good. A hospital system is showing concern for the whole person, physical, emotional, and spiritual. And that is part of the 10 tenets of Plane Tree. Spiritual care is in their 10. So having a hospital system show that concern for the whole person is beneficial to patients when they hear that coming in. What's another reason why it's good hearing that question? Mike, you're muted. Unmute yourself.
I think it shows caring from the standpoint of the hospital. It fits with, shows that it's available.
Yeah, okay. In a time of crisis, some people turn to their spiritual values to make healthcare decisions. Okay, how many of you have been in the ICU when they have to decide whether or not to turn off life support? And their faith tradition is going to dictate how that happens. So in a time of crisis, people do turn to their spiritual values. Another thing it does, if you're in a hospital system that has volunteers, that has a triage, has volunteers and chaplain support, it gets the ball rolling for the chaplains and the spiritual care volunteers. We get a heads up, hey, patient in room 403 is anxious and has asked for spiritual care support. So if that question's happening at the beginning, that helps us triage our day. And that was very handy when I worked in a big trauma center. I could triage the different things that were coming in. And then finally, number 4, we find out also if patients are ritual and gender specific for their spiritual care. Example, for the anointing for the sick and dying, priest, gotta be a priest, male priest. And some other faith traditions are male exclusive or female exclusive or ritual exclusive. Only people who are ordained or trained in that particular tradition can do that ritual. So we kind of gather that information and know what is important to the patient spiritually while they are in the hospital. Okay, so there are pros and cons to everything. What's bad about this question? Would you like spiritual care support given to you while you're in the hospital? Let's pick that apart. What's bad about it?
It might make an atheist angry.
Okay, possible.
Patient may not understand the question since spirituality is such a large concept.
Very much so. Yes, yes, yes. Good answers, both. Anything else? Okay. The first thing that's kind of bad about this question, it's only one question. And the person who's asking it has little or no qualifications to triage any kind of spiritual distress. To the people asking this question, it's something they're just checking off. And so there's not a deep level of screening beginning right there. And again, people are vulnerable when they come into the hospital, and they may get cranky if you ask them about their spirituality. They may get defensive, or they may get standoffish, or, you just got to learn to ask it. The people who are asking it try to be as neutral as possible, just as a, we do this, do you want this? Okay, check. That's how they're presenting it. Some hospital systems make this question, they mistake this question for a full spiritual care assessment. I've been in hospital systems that said, yes, we did a spiritual care assessment. We asked them if they wanted a visit from a volunteer or a chaplain. That's not a spiritual care assessment. That's just asking you want a service. And we're trying to educate hospital systems that there's more to this than what you think. Sometimes the answer changes from admission to discharge to hospice. It's a fluid thing, our spirituality. Some people are like, no, I'm great, it's all good. And by the time they get to hospice is, I want a chaplain, I want a priest, I want everything. I want to make sure everything's taken care of, or I'm scared to death, I don't want to die. And people are in that vulnerable state. So it's fluid, it changes. It's not a one and done kind of question. And then finally, spiritual and cultural diversity is not even remotely addressed by this question. Not even remotely. It's just a yes or no. But it's a beginning. And it's good that it's being asked. And it's good to let patients know that it's there. So in the hospital, a patient's been admitted, they've been asked, do you want spiritual care support? And let's say, for the sake of conversation, they say yes. So the next level tool that is asked, and this can be done by any clinician if they have a little more training, like a nurse or a social worker, spiritual care volunteer. The next level of triage is called the spiritual history. A spiritual history is a more in-depth tool that can be used by spiritual care volunteers to assess the ways in which a patient's spiritual and or religious history impacts their medical care. Spiritual histories, in contrast to spiritual screens, are dynamic and they may change the course of a patient's hospitalization. A spiritual history assesses the ways in which one's beliefs and values and participation in a spiritual or religious community impacts their medical decision-making. So it's kind of going down the next level, going down, digging deeper, finding out what are the values, what are your core values, what's important to you right now, and how can we, you know, if we can provide some of this support for you while you're here in the hospital. Now, silence your cell phones. Two tools that we use to gather a spiritual history. One is called FICA, F-I-C-A, and it was developed by a guy named Pukowski and Romer. And it's a little acronym, and it's I'll hold it up. You'll go ahead and get this, but it's faith, importance or influence of religious and spiritual beliefs and practices, community connections, and then address action. So you're kind of going through this little checklist in your mind. Okay, what is this person's faith or spirituality? How important is this person's faith or spirituality to them and their practices? Do they have community connections? Do they have outside clergy? Do they have outside priests? Do they have outside imams or shamans or whatever it is that supports them? Do they have that support in the community? If they don't, then how do we, the staff, address and have an action for it? You may have to provide scripture for someone. You may have to provide a rosary or mandala beads or sage, wrapped sage, or a variety of things. Whatever it is, these are things that can help bring soothing and calm to our patients, and these are some of the things we can provide. So you're assessing for what is their spirituality, what is their faith, spirituality, even atheists and agnostics have things that chill them out. How important is it to you? How does it influence? What are the community connections? And then what's the address and action? So that's called the FICA model. And again, I'll forward this and you'll have that. And the next thing about this, learn how to do this model conversationally. So that's why they came up with this acronym, FICA. Okay, FICA in the back of my mind. So you're talking to this person, hey, Jamie, how's it going? Gosh, you're here in the hospital. What brings you to the hospital? Okay, well, I'm a spiritual care volunteer. And do you have a faith or a spiritual practice that brings you comfort while you're here? Person answers yes or no. Okay, so is this something you do every day? Is this something that's really important to you in times of crisis or just being here in the hospital? You get an answer. Very important, and oh, I wasn't able to grab my Bible. Could I please get a Bible? Ding, we got it. We can do that. We can provide some scriptures or readings or whatever, or even just devotional material, upper room and such. Community connections. Do you have a clergy person you want me to call to come in, visit you, and offer you support? And yes, no. Sometimes if they are denominational exclusive, yes. It has been my experience, Catholic, Mormon, Jehovah Witness, and Christian Science really like their own providers. It's comforting to them. So you ask, hey, can I call this person? Sometimes they say yes. Sometimes they say no. You know, sometimes people just want to be left alone when they're in the hospital, or, those hospital gowns, not everything's covered up. And people who are in, a state of, it kind of conflicts with their modesty, and they may not want their male or female spiritual care provider visiting them when they're in that state. So sometimes they will transfer to the spiritual care provider because you're in a clinical setting, you're more accustomed to this, and hopefully you've had enough training to be easy around their discomforts and they won't feel so exposed, for lack of a better word. When I gave birth to my second son and they were helping me nurse, one of my parish members walked in and I was mortified, absolutely mortified. I did not want anyone in my faith community seeing me in this way. So that's just kind of an example of, in the hospital setting, this is totally appropriate and chaplain's going to see it all. Spiritual care volunteer may even see it all, but it's not appropriate for someone who's a peer in your faith community to see some of these things. Okay. All right. So then the address and action, you might provide stuff, you might provide visits, you might provide prayer on the spot, you might provide blessing, you might just let them know, hey, someone else will be following up with you and checking on you. There's a variety of services that you guys can provide as the program expands and you find out what you can do and, how to be with these people. So that's FICA. Another little tool for the spiritual history is called the HOPE model, H-O-P-E. And I know I'm going to butcher this name. It's a long, beautiful Indian name. I think it's Ananda Raja, Ananda Raja and Haidt. These were the two individuals who came up with this little history tool. And it says, it starts out with a triage. It says, what are the sources of hope, meaning, comfort, strength, love, and compassion for this patient? So immediately you've gotten away from faith and you've gotten broader. Like this is something that an atheist and agnostic may not get upset at because it's like, what's meaningful to you? What brings you comfort? That's not a religious-based question. So it's more open-ended. So what are your sources of hope, meaning, strength, love, compassion? The next level of that is, do you have an organized religion that brings you comfort or support? You're triaging, okay? Next question, what are your personal spiritual practices? What I run into a lot in hospice is, I was raised Baptist, haven't been to church for 50 years. These are my core values, and I'm coming back to that now as I'm dying. And so what we end up distinguishing is that this person is spiritual but not religious. They don't have a denominational tie. They don't have a religious, they don't feel comfortable being pegged down by a single denominational name, but they are spiritual. They pray every day. They meditate, they get out in nature, they talk to God, they bless their family, they have special things. Spirituality didn't leave when they stopped going to church. It just stopped being a denominational affiliation. So personal spiritual practices, this is what you're going to find out from these people. And you're getting their history and what their practices are and what's meaningful, what brings them comfort. And then the next one was, what are the effects on medical care and end-of-life care? And this is where we can start getting into the fun stuff, as I like to say. Some of our brothers and sisters in the Jehovah's Witness faith, they don't like blood transfusions. And so if they have an injury, which may require a blood transfusion, they're going to want to talk to their care team about what are some other methods and ways for which to accomplish my care that does not offend my religious tradition. Some of our other brothers and sisters think their view of life in the human body, life is still there if the heart is beating, even if the brain is dead. And they may not want to disconnect life support. So you can have someone who is completely brain dead, but the heart is still going, and they will not disconnect. And that is a faith tradition informing that decision. And so the family and the care team will have to engage in a conversation about, okay, so this is your faith tradition. These are the effects of the medical care on their body. This is what's happening. And, you know, what are the ramifications of that? How is this going to affect? Can we call in one of your clergy to help bring you spiritual comfort while we make some medical decisions? So it's a constant engaging of conversation. Hopefully it's gentle and respectful of people's beliefs and traditions. You know, we don't want to go tromping over everyone's sacredness. But I know there's some other examples of how, you know, end of life. I know in hospice, palliative sedation, some of our brothers and sisters think opioids are all bad. But when pain medicine is used correctly, you're not going to get addicted. You're just going to have quality of life. And but there's such a religious taboo to using any kind of opioid that some of my patients will suffer. They will not take it. It goes against everything that is holy to them. And some may have a religious epiphany. I had a Mexican Catholic woman who refused her morphine, even though she had cancer, bone pain. And she was excruciating, but her faith tradition said, and her faith affiliation was, the Mexican Catholics identify more with Good Friday, Jesus as the suffering servant. And so her suffering was cleansing her here on earth before she went to heaven. And so it was tragic and excruciating to watch this, but we honored her wish. You know, the biggest thing she got was Tylenol, and she died that way. But in her mind, her soul was 100% pure and went straight to heaven. That was important to her, and we had to honor that. So I have a tool that I like, and it's called Where to Begin the Conversation. And again, I'll get these to you guys. I'll get them to Joy, and you can have some copies and photocopy them and keep it in your folder while you go and visit people. And you're going to find one of these tools is just makes it work for you. You're going to like, yeah, I like this. I can do it. It just rises out of me organically. I got this little tool from the chaplains at UC Davis down in Sacramento. Excuse me, I need some water. Okay, where to begin the conversation? Number one, tell me what you know about your situation. Some people may be in the hospital and have no idea why they're there. We have people admitted to hospice who don't even know what hospice is or palliative care. A decision was made and they got transferred there and they have no idea. So they have not even begun to process the implications of their hospitalization, their disease progression, any of that. So this is a really good open-ended question, and it really gets to where a person cognitively thinks they are at. Now, this works good with people who are alert and oriented. This doesn't work good with people who are mentally distressed or mentally ill and not alert and oriented. So this is not something always to use, or you might have to modify it. The next question you ask is, how are you feeling about all this? You know, some people are happy to be in the hospital. I broke my leg. It's going to get fixed. I'll get out of this pain. Some people are like, we're here to have the baby. This is great. This is joy. Some people are we're here for the transplant. Finally, we've waited over a year for this liver. So there's a lot of reasons to be there. Some may be happy and some may be anxiety. You'll find out when you ask this question. The next thing is, of everything that's going on, what's most important to you? So like Roger said, this is a question that's not going to offend an atheist. It's not heavy on the religion. It's very open-ended. It asks someone, you know, you may get a big faith answer. I got an answer one time from a man who was on dialysis, and he gave me the secret to his heirloom tomatoes that he had been growing for generations. His family were heirloom tomato junkies. He was an atheist, but Dad burned the man could grow tomatoes really well. And he loved to tell everyone about it. And he loved being able to share that while he was getting his dialysis. Now that's meaning making. And who else is going to ask him that? Nurse doesn't have time. Social worker doesn't have time. Spiritual care volunteer can do that. And that adds that extra layer of compassion and human connection in the medical care center. And that's what chaplains and spiritual care providers do. Okay, there's another question on this. Tell me about your faith, or what does that look like to you? And so you'll find out some people might say, oh, I'm Catholic, I'm Baptist, I'm a Presbyterian, I'm Christian Church Disciples of Christ. Let me tell you about that. I'm Jehovah's Witness, I'm whatever, or I'm atheist, I'm agnostic. I hate organized religion, but I pray every day. And so I will follow up with, so if I were to say you are spiritual but not religious, do you identify with that statement? 9 times out of 10, they say, yep, I'm a spiritual person, but I'm not a religious person. I'm not affiliated with any kind of organized religion. So you know that there's some connection to God, higher power, universe, energy, whatever you want to call it, the great mystery, as Sanskrit says. So what does that look like to you? They get to tell you their story. They are the author of their story. They're the expert of their story, and we are the listeners. Okay, another follow-up question that is, where's the divine in all this? You know, some people are like, oh, God's right here with me. It's all good. And some people were, I'm so bummed out. I think God's abandoned me. Where the hell is God? You know, why did this happen? And that allows them to lament. That allows them to get those feelings out so they can find clarity about what they are feeling. And then the last question on this little tool is, how can I, as a chaplain, spiritual care volunteer, minister, help or support you? What can I do in this moment to be of service to you? And, you know, it sometimes 9 times out of 10 people go, pray for me. And then I'll say, what are we praying about today? Because I'm not going to make an assumption. I want to know what's on their heart. What do they need support around? Sometimes they may ask for prayer. Sometimes they may just say, sit here and hold my hand. I'm scared to death. And that's what you do. You know, in advanced training, clinical pastoral education, I do soothing touch now with my patients who are more on the new age spectrum. And so I do soothing touch and I get them into a place where they are so relaxed. And then I ask them, what's troubling you? And then poof, out it comes. But they can't get there until they've had good, positive connection with another human being, good positive energy, good feelings, the release of, I can't think of it right now. When our skin is massaged, there are certain places on our body, it releases happy chemicals, happy endorphins. Is that oxytocin, Joy?
Yeah, the endorphins.
Endorphins, okay. So there are certain places that you can massage on someone, maybe who is not even nonverbal. Like you can stroke down their arm, you can stroke right here across their brow. If they're in a wheelchair, I do the nape of their neck, which is 9 times out of 10 really, really stiff because they're always kind of in this position of rigidness. And it just helps them relax. It's another way of creating a human connection that helps them access their feelings and therefore get those feelings out and feel alleviated, you know, feel some relief. So that's something that I do. That's higher practice chaplain care. Okay, so that's my favorite little tool, where to begin the conversation. And this is why I love this little model. It's so open-ended. You can't come in making assumptions. You have to ask and find out what's important to them. So you can assess it for religious and non-religious patients. And that's what I like about it. It goes both ways. It's very conversational. It's easy to reference and it's non-threatening. My little dog, get up here. Sorry, I'm babysitting dogs. Ugh, and he's having a nut. So it's non-threatening. spiritual care volunteers, clergy, chaplains, any person who is in the vocation that represents the divine, mystery, holy, meditation, people will have baggage and hangups associated with that. And so our goal as the providers, we have to help people become comfortable around us so they don't just see our vocation and have their hang up reaction to it. We have to create that intimacy and that non-anxious presence so that we are that haven for them. So that's part of what spiritual care does. Okay, so the next level, that is the spiritual care assessment. A spiritual care assessment can only be completed by a paid staff who has access to the medical chart, preferably a chaplain who is board certified and has the advanced training, because the reason for that is Joint Commission requires it to be done by a chaplain. And after that assessment is completed, a care plan is created, documented, and entered into the medical chart. And that care plan touches base and is used in collaboration with an interdisciplinary team that is taking care of that patient. So here's an example. I had a patient at the TNI at Sutter Roseville who was Coptic Christian. Okay, so that's like Catholic, but the Eastern manifestation. It comes out of Egypt. And they have a belief that their saints and icons of their saints, little pictures or little statues of their saints, certain saints addressed certain things. So there was a saint you would pray to who would help bring healing. Now in the Coptic faith, proximity of the holy object to the patient is tantamount to that healing going to them. So we have this Coptic Christian patient, had a massive stroke, is hooked up to 1 million things in the TNI. Where are we going to find space for an icon or a picture that doesn't obscure any of the medical things that need to go on? And so I talked with the family and they're like, it's so important that it be close to them. And I talked to the nurses and they're like, well, you can't cover this and you can't cover this and you can't. And then we came up with a solution. Well, what if we took that picture and put it under the patient? And then that way you've got proximity and you have it out of the way so that the medical team can do what they need to do. Win-win. But you had to talk to the patient, you had to talk to the family, you had to find out what was important, and you had to broker a kind of, broker a way where the needs can be met. Everyone has to win in this situation, the patient's needs and the medical team providing the care. And that's what spiritual care volunteers and chaplains do. We interact with that team and help them know, hey, this is really important. I had a Lakota Indian woman who had ashes blessed by her shaman in an abalone shell, and housekeeping threw it out. They had no idea, none. They saw ashes. They thought it was cigarettes. They had no idea they had committed this huge faux pas. And so, she was like, they're never coming in here ever again, So I got in there, I listened, I found out what the problem was, talked to housekeeping and the general people there and all that, and did a little in-service. I said, if something looks unfamiliar to you, ask before you lift it up, touch it, or clean it, because you might inadvertently be touching something that's holy. Not everyone carries a rosary, everyone has something that's sacred to them. So it's just another part of that cultural humility. Ask what's important to you. Everyone on the staff needs to be doing that, not just the spiritual care volunteers. Okay, so that spiritual care assessment is done by a chaplain. A care plan is created. It's utilized in collaboration with their interdisciplinary team, providing the medical care for the patient. Why can't I teach you how to do a spiritual care assessment? One, you have to have access to the patient chart. You have to see what their history is. You have to see what the social worker intake note is. You have to see what the nursing notes are. You have to follow where the doctor's going. You guys don't have that access. So that's one of the reasons why we can't have you doing a spiritual care assessment. You have to create a care plan and follow through on it. Right now, you guys can provide some services and some in the now moment, pray, grab a Bible, call a clergy or a Buddhist monk, whatever, or a rabbi. You can call people to come in. You can provide that if it's of your faith tradition, but you aren't creating a care plan that addresses their spiritual care needs, their psychosocial needs, and how there's a clinical interface with the team. Number 3, you have to have the ability to triage to the highest point of need and distinguish the difference between positive religious coping and negative religious coping. And that is like advanced chaplain care. I just started learning that through palliative care training. So that's really beyond the provision of spiritual care you guys are providing. So in other words, if you want to get to the point where you want to learn how to do spiritual care assessment, then I would recommend start going to clinical pastoral education, start learning how to become a chaplain. And there are training centers down in Sutter and also UC Davis. I'm not sure how far up north they're doing any. Reading used to have some. But in those classes, 4 units of clinical pastoral education, you'll start getting the training to take your theological training, interface it with a clinical model, and how you become part of the medical care team and you can provide that care. So what I gave you was a history and a way to open the conversation so that you can find a way to be of service to these people, maybe ask the questions a little deeper. But honestly, I can't ask you to do a spiritual care assessment because you're not a paid staff. And that would kind of be unethical. We can't ask volunteers to do something that a paid staff member has to be doing. So that's the level of spiritual care that happens here in a hospital. So that's all I have right now. Questions or comments?
Fabulous.
Thank you.
Yeah, this is really helpful. Thank you, Mary. The beginning of the conversation questions are especially helpful to me because I've struggled with some of those, starting to build rapport and figure out what's going on with the patient. So I especially appreciate